Hey, Dr. McCann here, and this video is on the secrets of testosterone use in women. And of all of the female hormones, testosterone is definitely the most controversial. And I would say most doctors are not on board with testosterone supplementation for women. And this is definitely includes my specialty, OBGYN. As a matter of fact, chances are if you talk to your OBGYN about hormone replacement, they will actually recommend against testosterone, leaving patients to find care at med spas or wellness clinics. So why is this? Well, a lot of us were taught that testosterone causes blood clots and stroke, and I was one of these doctors. And when my partner told me that he was being trained on testosterone replacement in women, my first reaction was, why would you do this? It causes stroke. And this belief mainly stems from older studies that suggest testosterone increases the chance of cardiovascular disease. However, like other hormones, there's new research that shed light on the benefits of testosterone therapy in women. And with the rapid proliferation of wellness clinics, testosterone use in women has skyrocketed, and medical studies are trying to keep up. And globally, there's abundant interest in testosterone supplementation for women. This has even prompted a global consensus position statement on the use of testosterone therapy in women. So what's the big deal with testosterone anyway? What would it even help with? Well, officially, it's approved for HSDD, but both clinicians and patients have noticed significant well-being benefits, including improvements in fatigue, mood, brain fog, among other things. As a matter of fact, as far as symptomatic relief goes, that was also addressed decades ago. Back in 2002, an expert panel published the Princeton Consensus Guidelines, and the recommended definition of androgen deficiency in women included a diminished sense of well-being or dysphoric mood, persistent unexplained fatigue or lethargy, and sexual function changes. And just for your knowledge, androgen deficiency has never been officially recognized. Even though there are decades worth of recommendations and studies, as of now, the global consensus position statement on the use of testosterone therapy in women is the most comprehensive evidence-based guidelines to date, and this should supersede all previous guidelines. Officially. The current recommendations only gives guidance for the usefulness of testosterone for what's called HSDD, which I guess is at least a start. Other well-being benefits are not included in the current recommendations, mainly according to the global panel because the trials have not yet been large enough or long enough to definitively determine the effects of the safety profile of testosterone in regards to cardiovascular health, breast cancer risk, cognitive health, mood, and musculoskeletal health. And as you can see, several recent meta-analyses provide safety reassurance for the use of transdermal testosterone therapy. However, the trials to date have neither been large enough or long enough, as I just mentioned. So this means it's not that it's not safe and it doesn't help. It just means more and longer studies are needed to determine this. So I know this is going to be a long video, and it's going to actually be divided into chapters. First, what is testosterone and how it acts in the body? Second, how testosterone affects different body functions, including cardiometabolic health, brain health, musculoskeletal health, and body composition, as well as breast health. Third, who are the candidates for testosterone therapy? Fourth, the formulations of testosterone therapy. And last, it's going to be my own clinical experience. So in this video, I'm going to share the official recommendations and also give some clinical thoughts I've had experience after treating women now for over a decade. So let's dive in. Testosterone is made in the adrenal glands and the ovaries directly. And it's made from precursors. So it's made directly and from precursors. And these precursors are turned into testosterone in different parts of the body. Testosterone is metabolized or broken down into DHT, or it's changed or aromatized to estrogen. And all three of these, the testosterone, the DHT, and the estradiol, they can affect multiple different cell signaling pathways in your entire body. So it regulates what's called cellular metabolism. So cellular metabolism is all of the reactions that have to take place in your body to maintain life and perform biologic functions. Both testosterone and DHT, which is actually the most potent androgen, act directly in the nucleus of your cells on your genes to tell them what to make your cell work best and most efficiently. And it also works on non-genomic pathways. Androgen receptors are found in multiple female tissues, including the ovary, the endometrium, breast tissue, bone, brain, and heart. So let's start with the heart. Testosterone and cardiometabolic disease. And again, this is the big one on why a lot of providers are against testosterone therapy in women. As expressed earlier in this video, the general belief is that testosterone increases the risk of cardiovascular disease. And this belief stems from older studies that incorporated multiple different formulations of testosterone supplementation, including oral. However, research actually shows the opposite. It shows that hypoandrogenic or low testosterone is detrimental to the cardiovascular system. And at physiologic concentrations, testosterone has a favorable effect on vascular tone that direct effects on the blood vessel wall. However, both in this review and the global consensus statement state that testosterone does increase LDL with oral but not transdermal formulations. And as you can see from the global consensus statement, non-oral therapies and doses that approximate physiological testosterone concentration for premenopausal women have shown no significant effects on lipid profile and has not been associated with increase in blood pressure, blood glucose, or hemoglobin A1C. However, trial findings are limited in that they have excluded women at a high risk for cardiometabolic disease, and they've been relatively short duration. So, moving on to testosterone and brain health, evidence from basic and clinical studies suggests that hormones affect cognitive decline and progression to dementia in women. Findings have shown that estrogen and testosterone are neuroprotective, have anti-inflammatory actions within the brain. Male studies, testosterone has actually been shown to improve Alzheimer's disease, and it's currently even being explored as a therapy. Studies involving females have shown that higher rates of the free testosterone levels were associated with lower rates of the beta amyloid plaques, the plaques that cause Alzheimer's, and that estrogen and testosterone influence these amyloid deposits in the brain. And it improves the brain ability to metabolize glucose and improve blood flow. Officially, from the global position statement, there is no sufficient evidence to support the use of testosterone to enhance cognitive performance or to delay cognitive decline in postmenopausal women. Testosterone and musculoskeletal effects. There are androgen receptors in both the bone, osteoblast, and osteocytes, and it's thought that testosterone acts with estrogen, improving bone mineralization. Testosterone stimulates the osteoblast proliferation, blocks osteoclast activity, while estrogen inhibits osteoclast proliferation. Basically, they both work together to help build your bones. With respect to body composition, we all know that testosterone increases muscle mass, and studies have shown that high concentrations of free testosterone have been directly associated with greater muscle in older women. A little interesting, however, studies show that while testosterone supplementation in males do decrease the bad or visceral fat and promote fat breakdown, females, the results are not as convincing. It's still unclear. We know testosterone increases muscle mass, but its effect on the subcutaneous and visceral fat or fat around the organs, they're a little bit less known. So clinically, I definitely see this. With testosterone supplementation and when it started, if women start or increase exercising and resistance training, it increases their muscle and can definitely decrease the fat. However, if a woman is not active and doesn't become active, I have seen weight gain with this. Officially, however, you guessed it, in summary, although the findings of epidemiological studies suggest that although testosterone has an important anabolic role for muscle and bones, clinical trials have been small and mostly short duration. So the effects of testosterone therapy on musculoskeletal health and the risk of fracture remain uncertain. So, testosterone and breast health. And this is interesting to me because there's been some suggestion that testosterone could actually protect against breast cancer. Here are just a few of the articles supporting this. So, testosterone therapy has been shown to be breast protective in both pre- and postmenopausal patients. And also, there is an abundance of evidence that androgens are breast protective. In vitro breast cell cultures and in vivo primate studies support that testosterone's direct effects on the androgen receptor is anti-proliferative. And another, it has been known for over 70 years that testosterone is anti-proliferative in the breast and inhibits stimulatory actions of estrogens. Another more recent long-term cohort study entitled Testosterone Therapy in Breast Cancer Incidents followed over 2,000 pre- and postmenopausal women receiving testosterone therapy with and without estrogen. The results demonstrated that the incidence of breast cancer was 40% lower than predicted. However, the official findings and statement from the Global Consensus Panel, again as follows: testosterone does not increase mammographic breast density. Short-term transdermal testosterone therapy does not impact breast cancer. Data of trials are insufficient to assess long-term breast cancer risk, and there is no data to support the use of testosterone therapy to prevent breast cancer. So while this is very reassuring that testosterone does not contribute to breast cancer, it can't be said for certain that it actually helps prevent breast cancer. So summarizing, overall testosterone therapy and serious adverse events. Number one, testosterone therapy for postmenopausal women in doses that approximate physiological testosterone concentrations for premenopausal women are not associated with serious adverse events. The trials have excluded women at high cardiometabolic disease risk, and most have included women taking concurrent estrogen therapy, so it is not generalizable to a more at-risk population. And safety data for testosterone in physiologic doses are not available beyond 24 months. So the one diagnosis that testosterone is actually recommended for by the Global Consensus Panel, HSDD. So bottom line, officially, who should actually take testosterone? And that's postmenopausal women and women in the late reproductive years with HSDD. As mentioned previously, many practitioners and patients report a significant improvement in energy, mood, and brain fog and joint pain with testosterone supplementation. And that is why it was considered in the global position statement. Again, it's not that it doesn't help with these things, it's that currently there still isn't large enough trials and long enough trials to prove it scientifically. And this is why the panel put together Section 14, which is recommendations regarding the design of future trials of physiologically dosed testosterone. Everybody wants more sound scientific answers, and remember, when medical data is misinterpreted or the results are released exponentially, it could be a repeat of the Women's Health Initiative, where women were and still are scared to take any hormones. So which type of testosterone is appropriate to take if you're going to take it? First, remember, for women, there are no systemic testosterone products approved by any national register except in Australia. So prescriptions are off-label and not covered by insurance. So it's all cash when it comes to payments. And as it states over and over and over again in the report, the recommended testosterone dose, specifically for HSTD, is transdermal testosterone patches or gels, creams. The patch dose would be 300 micrograms, or for the gel, or really any other formulation, it would be started at 1/10 of the recommended male dose. And this is based on the findings that normal testosterone levels in premenopausal females are 1/10 of those in males. Transdermal administration allows testosterone to be continuously absorbed for 24 hours with no dose accumulations. Testosterone is what's called lipophilic, which means it permeates the skin better than other hormones. Like progesterone does not permeate the skin very well at all. So either a patch or gel after it gets on the skin, it has to go through all the layers of the skin, the stratum corneum, the epidermis, the dermis. Then it's taken up by the capillary blood vessels into the circulation. The skin provides what is called a depot effect, meaning the testosterone can't go through the skin all at one time. The stratum corneum quickly. It has to go at a certain rate. So this helps to provide continuous delivery instead of peaks and troughs. Now, having said that, it's not perfect. There can be a lot of individual variability based on the skin location, the thickness of the skin, the hair follicle density, the solvent evaporation, skin dehydration. You get the picture. They can be at temperature, the humidity. So downfalls with testosterone patch specifically include a skin reaction, and this is why for males now, there is only FDA approved gels. Complications with the patch as far as irritant, we're approximating about 30%. So the potential advantages of testosterone transdermal gels and liquid include the ease of application. There's less skin irritation than patches and more consistent serum testosterone levels than other formulations such as injections. Clinically, however, I would love to try a patch, but I can't find a compounding pharmacy to make it, despite all the compounding pharmacies nationwide advertising for weight loss drugs and peptides and everything else. I can't find one to make a patch. However, I have used testosterone cream in patients, and honestly, the results haven't been great as far as symptomatic relief. I generally don't see symptomatic relief with the creams, but I do prescribe it if a patient wants to try it. So let's look at other choices out there. Oral testosterone, and there was a pill called Estratest that is no longer manufactured, but a compounding pharmacy can make it. It's not recommended because it's associated with adverse lipid profiles and negative effects on the HDL and the LDL. And there is some question of if it contributes to certain liver cancers. So personally, I don't ever prescribe oral testosterone. And really, 15 years ago when that was the only thing available, I did prescribe it. But for low libido, I honestly didn't have really any improvement in symptoms with almost any of my patients. So in my experience, it's ineffective anyway, and we know that this one can have adverse cardiometabolic events and potentially lead to liver cancers rarely, so I just don't prescribe oral. Now, there's something called the troche that's under the tongue. In theory, this should avoid metabolism by the liver. However, the International Society for Study of Women's Sexual Health guidelines state that it can result in substantial gut absorption through swallowing the saliva, and it should be considered as oral and therefore not recommended. There's non-oral therapies, and this would be the pellets and the shots. These are not recommended because they can cause extra physiologic elevations of testosterone. However, the guideline states that in doses that approximate physiologic testosterone concentrations for premenopausal women, there are no significant adverse effects on lipid profile over a short time. But let's start with the shots. To be absorbed from a shot, testosterone has to be what's called esterified, and then it has to be dissolved in oil. After injection, the added benzoyl alcohol helps remove the testosterone from the oil. Then the fluid that's in your body changes it back to the original testosterone form, where it can be absorbed. So with intramuscular injections, you may initially get a very high serum concentration, then it rapidly decreases, and this all depends on how often you get the shot. If your provider is only giving you the shot once a month, then a high dose will be needed to still let you have effects all the way to the following month. And I've seen this very high levels with this kind of dosing. Mainly women will be placed on this maybe monthly and come to my office. I've seen them complain of significant anxiety, and sure enough, after checking the testosterone level, I've seen it be in the 500 to 600 range, which is very, very high. So this dosing is definitely not recommended. There is something a little bit new, however, than that subcutaneous administration. So instead of IM, it actually goes just in the subcutaneous area like the weight loss shots, and that's easier to do at home anyway. In contrast to IM, after a subcutaneous administration, like the weight loss shots, the drug is delivered to the hypodermis in the adipose tissue of the underlying dermis, which is not only less vascularized compared to skeletal muscle, but the flow in this region does not increase significantly with physical activity. And since the blood flow at the injection site of the drug administration influences the pharmacokinetics of the administered drug, subcutaneous injections display more stable vascular absorption patterns compared with intramuscular. This means, in theory, you should not get that high in the peak and then it drop off. And since the injection is easier to do at home, it can be done weekly or even twice a week, which can further help with high peaks. But remember, even with the IM injections, there's not a lot of research and it's not recommended. So studies regarding subcutaneous administration and if it's better, they're definitely not out there. Technically, still not recommended by the Global Consensus Panel. Again, the reason the IM is not recommended is it has wide excursions above physiologic levels. It's not recommended, and the fluctuation in serum testosterone levels can result in mood swings, and it can actually decrease libido. So the other injectable form is subcutaneous pellets. And this might be the most common form of testosterone supplementation, but it is definitely not new. It can date all the way back to the 1930s, and you see this article from the 1940s is all about testosterone pellets. So it's been around for a long time, and officially they're not recommended because occasionally they had markedly elevated testosterone levels with erratic release over time and cannot be removed. However, several earlier studies in men did show that testosterone pellet implants released a steady rate of 1.3 milligrams per day per 200 milligram pellet implant. So in theory, the benefits of the pellet should be a steady, predictable release rate. As hormone pellet implants develop capillary blood network about them, and their absorption is based on cardiac output, meaning that the greater your cardiac output, if you're exercising more or even through stress, the more of your needed hormone will be absorbed. Even though these aren't recommended, let's take a look at a study that one of the pellet companies submitted. This was a retrospective study, included over 1 million procedures, with over 85% of that being women. And it was looked at over 7 years. Again, around 380,000 patients, 85% were women, half with premenopause, half were postmenopausal. The continuation rate is what they were looking at. It's over 93%. So women love the pellets. And the complication rate was less than 1%. And the most common complication was the pellet extrusion. But I'm going to show you this table here of what they were actually looking at for complications. And it wasn't just infection, bleeding, extrusion. It was other complications. And you can see from the total complication rate was low, and specifically very low for cardiovascular complications. This company did recommend that this study be used to motivate more studies on chronic disease. So this is just another reassurance that in general, as long as the level's not too high, they're safe and effective. However, it is important to note that the target levels in this study was a total testosterone in female around 150 to 250. And the average level in female at 4 to 6 weeks was around 300. And this is technically 4 to 6 times higher than the upper limit of what has been accepted as the normal for endogenous production. And the complication rate was still low. Now, of course, as all things testosterone, there is also debate on the normal production and ranges in women. In the International Expert Consensus Resolution from 2017, there's a resolution 2 that says serum testosterone levels do not correlate with symptom of testosterone deficiency in women. Optimal ranges of serum testosterone levels in women have not been established. Although women produce 200 to 300 micrograms of testosterone a day, serum levels follow your circadian cycle, menstrual cycle variation, making it difficult to define normal ranges. And so I'm throwing out a lot of different panels, studies, recommendations, and this just underscores the importance and controversy surrounding testosterone in women. And remember what I said at the beginning, technically, the global consensus guidelines supersedes everything else that was done, but I am providing you with the information. But now we're going to move on to my clinical experience. So clinically, I've had great success with hormone pellets, and it's really great to truly change a woman's life, to have them come into the office. They're complaining of mood changes, fatigue. They don't feel like doing anything. They have no libido. Their relationship is not good. They don't feel like themselves. They're crying. And instead of me saying, oh, good luck with that, it's just aging, I can actually say, yes, I can help with that. But clinically, the range that women experience these significant improvements, the well-being improvements such as energy, libido, clinically has been in the 250 range as mentioned in the study. Just for reference, for providers that specialize in gender-affirming care, it is acceptable to get the testosterone for transgender males up to 1,000. And a lot of the studies, the levels were in the 700 to 800 range. So there is a lot more studies, and definitely that's not what I aim to get my patients at. I aim to get them at around that 250 level in the symptomatic peri and postmenopausal women. Because if you get them higher, you can actually have the opposite effect. Again, it can worsen mood, it can cause agitation, it can make libido worse, you actually feel too tired, and so you don't want to get it too high. And if it's just a little bit high, you can still have side effects like facial hair, male pattern balding, although that's mainly with higher levels, voice changes, acne. So there can be side effects. So here's the bottom line. Pellets aren't for everybody. It is a procedure. There can be side effects. If your level gets too high, they can't be removed. So if you feel agitated, angry, moody, there's no way to get rid of it. So yes, there are definite side effects of testosterone therapy in general with the pellets. So all of the downfalls and reasons that they are not recommended definitely can be true. That would just be a conversation to have with you and your provider that specializes in hormonal care. So in conclusion, testosterone use in women is extraordinarily controversial. It's becoming more recognized as an important hormone in women's health, and studies are ongoing. I encourage women with symptomatic menopause or perimenopause to try estradiol and progesterone first. If appropriate and your symptoms don't resolve, then we can discuss the benefits and risk of adding testosterone. I encourage everyone to find a provider that is specialized in hormonal therapy so the benefits and risks can be thoroughly explained.